Everyone, I'm Lauren. I'm one of the third-year residents, and as Dr. Labiat said, my presentation is called Don't Go Breaking My Heart. But we'll base the discussion today off of the preferred practice patterns that are released by the AAO. And really the point is not to decide if an answer is right or wrong, but it's to review what we have in the literature and what guides our management for certain types of retinal breaks. I think some scenarios are easier, like we saw in the voting, and then some, of course, require discussion. And really, I'll just preface everything with the studies are hard to review because the limitations there are many, but the several big ones are the status of the vitreous is not always mentioned in natural course or clinical course studies of retinal break. So that's a big kind of limitation to comparing studies. The other is the patient populations are very different. Refractive error is not always mentioned either. So it makes it difficult to compare the scenarios and the clinical course outcomes or natural history. But we'll review what's available and how the preferred practice pattern is created. So we'll just start briefly with some retinal break definitions, and we'll go relatively quickly through these because most of us know, but a retinal break is a full thickness defect in neurosensory retina. Horseshoe tear or flap tear, like you saw in the examples, are usually signifying continued traction on the apex of the flap tear by the vitreous. And then round holes, of course, would refer to round breaks that sometimes have an avulsed piece of retina or the operculum, like you mentioned in the third example. That usually signifies relief of traction on the retina, but not always, as we'll kind of discuss in operculated breaks. And then, of course, just to kind of frame our discussion today, the rhegmatogenous retinal detachment is what I'll refer to the whole presentation when I talk about RDs. And those are separation of neurosensory retina from RPE by subretinal fluid. And then we'll talk just briefly about the epidemiology. So the whole point of the discussion, right, is to prevent or attempt to prevent rhegmatogenous retinal detachment. So that's why we treat them with laser retinopexy most commonly in an ER, but cryopexy and other therapies. But before the 1900s, most of the descriptions about RRDs were using words like incurable, certain vision loss, blindness, and spontaneous reattachment of retina, of course, is very rare. So recognition that the retinal break, however, was part of the cause of rhegmatogenous RD and not a consequence, which was, I think, the prevailing thought before Dr. Jules Gonan described breaks as being causative in a rhegmatogenous RD. I think he was actually nominated for a Nobel Prize for this. And then in the middle, there's a photo of ignipuncture, which was how early treatment of retinal detachments was done with coagulation transscleral. But the history behind it is really kind of interesting. And so that just to kind of frame the discussion and why we're even talking about preventing RDs. And then, as most of you already know, but I'll review to kind of, set the stage for this. We know that kind of the recipe or the required pieces of a rhegmatogenous RD are, syneretic or liquefied vitreous so that it can travel subretinally. And then we talked about the full thickness break to allow access to the subretinal space. And then typically this is seen in rhegmatogenous RDs in the setting of an acute posterior vitreous detachment. But persistent traction on a break is how we kind of allow the space to be accessed by liquefied vitreous. And just briefly to also kind of give some context to the discussion, reported incidents, again, this is hard to study, between 6 and 18 people per 100,000 person years. Surgical outcomes really vary, of course, by surgeon, study, patient, and what was done. But in general, first-time reattachment failure rate can reach 20% in some reports. Like I said, that will vary by geographic and who's doing the surgery, et cetera. Reoperations can be unsuccessful. Vision, like I said, this is also confounded by many factors, but can be worse than 20/50 in one report in over half of the patients. And then, like most of us know, reattachment spontaneously is rare, so we intervene, and that's why it's a worthwhile goal to try to prevent a rhegmatogenous retinal detachment. So then we get to the question of the examples, which I think is kind of interesting to have all of us think about what we would do, right? Because we are training together. But in general, the considerations for if you would treat a retinal break are many, and the answer is not yes or no right away over the phone, for example. So you kind of do need some more information about the patient. I won't list everything, read everything here, but you can see that important ones, for example, are myopia. With increasing diopters of myopia, there's an increased risk of rhegmatogenous retinal detachment. What happened to the fellow eye? And then importantly, what's the status of the vitreous? Because like I said in the studies to compare each other, it's really hard to know the patient's risk if you don't know the status of the vitreous and if a PVD has occurred or if you think it's occurred. And then there's precursors we'll talk about, like lattice degeneration, that are often cited as precursors to RRDs. So we'll start with the horseshoe tear because the preferred practice pattern, if you look at the highlights, goes by type of tear. And then they mention if the patient is symptomatic or not to help guide your management. So the flap tear, most of us are familiar with, especially us residents in the ER. This is the usually in an acute symptomatic patient following a PVD. So that's the first part of who we'll talk about. The horseshoe or flap tear has traction at the apex of the tear typically. Schaefer sign and vitreous hemorrhage we all recognize as signs of increasing the probability of finding a retinal break, not always at the initial visit, but increased risk. So now let's kind of get into the material and where the preferred practice pattern guidelines come from by this expert panel that reviews available literature. So I won't kind of inundate with tons of data, but if you look at one paper, for example, that did a natural course study or followed the clinical course, there were symptomatic patients, 15 of which that were observed. Out of those patients, 5 went on to retinal detachment. 4 of the breaks were symptomatic horseshoe tears. So that gets us around 30 or so percent progressing to RRD. And that's kind of one of the quoted numbers. There's another paper that demonstrated this by Dr. Matthew Davis. Similar numbers, observing 26 horseshoe tears in patients that were symptomatic and observed. And then in the 9 of them that went on to detach. So again, a similar kind of number that gives us the foundational widely quoted statistic between 30 and 55. Other papers were higher. But then the important thing for us is, so what happens if we treat, and does intervening do anything? So we always counsel the patient that it doesn't guarantee they don't detach, right? But when we're having the discussion. But if you look here, I'll show several examples, or 2 examples. One study showed out of the 74 eyes with symptomatic tears that were treated, 1 went on to detach. It's relatively soon after the laser was applied as well. So we talk about that risk with patients often. And then this paper I really like, it's a more recent one by Dr. Smitty, Dr. Flynn, and Dr. Garoon that looked at treatment of symptomatic tears. And so although the results aren't totally broken down by symptomatic versus asymptomatic, nearly everybody was symptomatic in the study, you can see there. And then they were treated with laser retinopexy. And of the treated, so you can see that 23 went on to retinal detachment, which gives us kind of similar, and I'll show you the range of how many people progress to RRD if we treat the retinal breaks. This is a nice table actually in one of the textbooks, but it kind of collates the data. So if you look at the treated and the highlighted column with the circle around it, we get kind of similar values if you treat retinal breaks prophylactically. And so comparing that to the 30 to 50% of untreated, it's a worthy goal or worthwhile goal to try to prevent the RD by treating the break. And so the recommendation is, I think, relatively universal or widely accepted that we treat symptomatic acute tears, like you mentioned on the second example. So we went over symptomatic and untreated and the high rate of detaching. Symptomatic and treated do relatively well to that number, but then the real kind of meat of the discussion is what happens to the asymptomatic patients. And this is where I was saying it gets really difficult to kind of precisely talk about the data, because I can't tell you everything about every study in a short amount of time, but comparing them is very difficult because the eyes are so different. But for example, Dr. Davis's study looked at 70 asymptomatic tears. And of those, 12 had subclinical detachment. I'll define it for you briefly. That's fluid about 1 disc diameter from the break, but not more than 2 disc diameters posterior to the equator. It's very specific and not really used as much today, but that's how the study was defined. And so 4 of those went on to detach. Of the 58 without significant fluid around the break, 9 went on to detach. And so these are the untreated eyes. Bayer's natural history study looked at 45 asymptomatic breaks, and that was a long follow-up, near 11 years. 19 had fluid around the break, like I just described, but not posterior to the equator. And then 3 overall of those observed eyes went on to detach. So 2 had extension of the fluid posterior to the equator, and then 1 over 14 years developed a clinically significant rhegmatogenous retinal detachment. So that also kind of brings us, we looked at the numbers now and we looked at what we feel kind of convinced about, which is treating an acute break. But when we talk about treating asymptomatic breaks, there are several limitations. So I guess one of the biggest ones that's cited widely is that we treat in areas that we see or perceive as abnormal, but that retinal detachments later occur from new breaks in previously normal retina or untreated retina. So one of the arguments for observing asymptomatic breaks is that, are we causing more problems? There actually are some studies about complications of laser, of course. And then are we actually preventing what we think we are? You could argue we're preventing it from the breaks you saw, but then there's new ones. So in one study, for example, you can just look at the highlight in the box here. You don't have to read the whole table, but new breaks were seen in almost 50% of the eyes in untreated retina of the eyes that went on to detach. So I kind of understand why we'll talk about this now in the preferred practice pattern, but there's not really a good recommendation or sufficient evidence to recommend treating every asymptomatic break. And then just to kind of convince you more or top this off, if you look for reviews, so there were reviews performed by Dr. Wilkinson that found, of course, that there's not a prospective study to look at treating asymptomatic breaks. It would be difficult to do and would take long, and none exist right now that can guide management, or at least that are accepted by the preferred practice pattern. So you can kind of guess the conclusion there after a lot of talking is that there's insufficient evidence to recommend treating all asymptomatic breaks. And that's kind of a highlight from the preferred practice pattern. And that's why I say it's kind of hard to answer the question quickly on the phone, yes, treat, don't treat, because the eye and the patient matter. What's the fellow eye, refractive status, et cetera, symptoms. So that makes it kind of difficult. And then we'll briefly talk about operculated breaks because I showed the example. As you know, that's kind of a piece of avulsed retina that usually represents traction relief in that area. There's examples here. You can see the operculum. There's some nice profiles by Dr. Beyer of peripheral retinal lesions that I think are kind of helpful to look at. And so asymptomatic operculated breaks and round holes very rarely lead to detachment. This is pretty readily accepted. So two other studies by Beyer and Dr. Davis looked at asymptomatic breaks. The Beyer study was over 11 years and none went on to have clinical RRD. But like I said, in that study, they accept some fluid, and I defined it for you earlier. And then in the Davis study, actually none progressed to RRD, and most of these were fellow eyes of retinal detachment eyes, and they had operculated breaks that were observed. So the preferred practice pattern actually recommends usually observing asymptomatic, atrophic, or operculated breaks. So that's kind of applying to our third example that you discussed. You could watch that, as you rightly said. And then we'll kind of start to wrap up here, and we'll look at other possible precursors of retinal breaks. This is kind of also interesting part of the discussion because we hear a lot, one widely quoted study by Folk that I'll talk about, but you might hear people say, what does the other eye look like and does it have lattice? And some people tell you to laser around all of the lattice, which gets a little bit dicey because some patients have it over 8 clock hours easily. And so if you look at lattice degeneration, it's present in 8 to 12% of the population. In RRDs, it's involved in about 30% of cases, though. And so the question becomes, do we treat all of it to prevent detachment? And you can probably guess, in one study by Dr. Beyer observing non-fellow eyes with lattice, so this is non-fellow, there was no prophylactic treatment to the lattice degeneration. Tractional tears occurred in 2% of the eyes, and then the RD happened in 3 of the 150 patients that had atrophic holes. So we kind of conclude from this that we don't prophylactically treat lattice degeneration. And so the preferred practice pattern also observes this, and lattice is included in the recommendation when it involves atrophic holes to usually observe. Like I said, some people quote the study by Folk, and we'll get to it. Some people quote the study by Folk that recommends treating all lattice detachment, lattice in a fellow eye. But that study actually had its own kind of limitations, including loss of benefit after greater than 6 diopters with more than 6 clock hours of lattice. They didn't see the benefit of preventing the RRD anymore. So that's a consideration. And then cystic retinal tufts are always included in the section of possible precursors. So I wanted to keep them here for completeness sake, but you can have small peripheral tears associated with cystic retinal tufts. I think a lot of us see these or think we see them in the periphery and don't really know kind of what to do about them. But usually these are a low risk lesion and you can observe typically. Obviously related to a break, it changes the discussion. And then just lastly, we'll talk about the fellow eyes. I just wanted to include this study so I could show you the number of the percent of fellow eyes that was seen in a recent study to have lattice. So if you look, almost 15% of fellow eyes had lattice present, and about 7% had a rhegmatogenous retinal detachment in their fellow eye. But the important thing here to kind of answer the question for fellow eyes is, should we treat? If you remember, I discussed the percent of patients that detach from new breaks. And so we're kind of limited in recommending to treat all lattice, even in fellow eyes. And so the conclusion there also is that we don't really do it. But this is the widely quoted study by Dr. Folk that looked at this. And the argument was to treat all of the lattice. But as you can see, there's some limitations in that because the benefit's lost at certain refractive error. And then, like I said before, 30 to 50% can have new breaks, especially with a new PVD in untreated retina. You can also refer to the end of the preferred practice pattern. The table nicely summarizes everything we discussed today. And so in conclusion, the acute symptomatic horseshoe tears are responsible for RRDs in up to 50%, 30 to 50, so a high number. The conclusion is to treat those, like you said.